Next, let's look at the formation of the GI tract. The primitive gut can be divided into the foregut, midgut, and hindgut, with each segment giving rise to specific gut and gut-related structures later in development. Luckily, these structures correlate well with the position of the embryonic structures. The foregut contains the structures from the pharynx to the duodenum, the midgut from the duodenum to the transverse colon, and the hindgut from the last third of the transverse colon to the rectum. The blood vessels that supply these structures are the same throughout development. In week 6, the midgut herniates through the umbilical ring as the fetus cannot yet accommodate the size of the midgut. At week 10, the midgut returns to the abdominal cavity and rotates around the superior mesenteric artery. Interesting pathologies can result from developmental defects. For example, developmental defects of the anterior abdominal wall can be due to a failure in rostral fold closure, resulting in sternal defects, incomplete lateral fold closure, which can result in omphalocele, discussed in more detail later, or gastroschisis, and inappropriate caudal fold closure, which results in bladder exstrophy with part of the bladder outside the abdominal wall. Duodenal atresia, which results from a failure of the bowel to recanalize, is associated with trisomy 21. Jejunal, ileal, or colonic atresia is due to a vascular accident during development, leading to ischemia and narrowing or obliteration of the affected area. This results in an apple peel appearance of bowel and is also called apple peel atresia. Two other developmental anomalies that are important to mention are gastroschisis and omphalocele. Gastroschisis occurs when the abdominal contents extrude through abdominal folds and are not covered by a peritoneum. In contrast, omphalocele is when the abdominal contents herniate into the umbilical cord, as seen in this image. The abdominal contents are covered by a peritoneum. When an abnormal connection between the esophagus and trachea occurs, it is called a tracheoesophageal fistula. The figure shows some of the different subtypes, but the most common subtype is a blind upper esophagus and a lower esophagus that is connected to the trachea, which you can see in the second picture. Tracheoesophageal fistula can cause cyanosis, choking, vomiting with feeding, an air bubble in the stomach on X-ray of the chest, polyhydramnios due to the infant's inability to drink, failure to pass an NG tube into the stomach, and pneumonitis. Congenital pyloric stenosis occurs when there is a narrowing of the opening from the stomach to intestine as a result of hypertrophy of the pylorus, causing obstruction. On physical exam, a palpable olive mass can be felt in the epigastric region and commonly presents in the first weeks of life, around 2 weeks, with non-bilious projectile vomiting. Congenital pyloric stenosis is typically treated by surgery with an incision to relax the pyloric sphincter. Continuing along the gastrointestinal system, the pancreas is derived from the foregut and hence is endodermal in origin. Pancreatic development begins with the formation of ventral and dorsal buds, with the ventral bud becoming the head and uncinate process, and the dorsal bud becoming everything else, including the body, tail, isthmus, and accessory pancreatic duct. When the ventral pancreatic bud encircles the second part of the duodenum, this forms what is called an annular pancreas, and this encircling can result in duodenal narrowing. Pancreas divisum occurs when ventral and dorsal buds fail to fuse, leading to exactly what it sounds like, a divided pancreas. The spleen is not derived from the foregut, but rather is derived from the dorsal mesentery. It is, however, supplied by an artery of the foregut, the celiac artery. Let's now talk about the development of the urinary tract system, a highly tested subject for step 1. The development of the kidney proceeds through a series of successive phases, each marked by the development of a more advanced kidney, the pronephros, mesonephros, and metanephros. The pronephros develops in week 4 and is largely non-functional. It quickly degenerates, and the mesonephros functions as the interim kidney during the first trimester, then later contributes to the male genital system. During the 5th week of development, the first signs of the metanephros, or the permanent kidney, appear and it develops a ureteric bud. The ureteric bud is derived from the caudal end of the mesonephros and eventually gives rise to the ureter, pelvises, calyces, and collecting ducts, being fully canalized by week 10. The ureteric bud also interacts with the metanephric mesenchyme, which induces differentiation and formation of the glomerulus and renal tubules. Aberrant interaction between these two tissues may result in several congenital malformations of the kidney. Nephrogenesis continues through weeks 32 to 36 of gestation. As the fetus grows, the kidneys rotate and migrate upwards. The uteropelvic junction with the kidney is the last to canalize and the most common site of obstruction, or hydronephrosis, in the fetus. Let's now look at some pathology related to improper kidney embryogenesis. A commonly tested condition is Potter syndrome. In Potter syndrome, bilateral renal agenesis is caused by malformation of the ureteric bud. The fetus cannot make urine, which means there's no urine to contribute to the amniotic fluid, which leads to oligohydramnios. Potter syndrome is associated with limb deformities, facial deformities, and pulmonary hypoplasia. Horseshoe kidney is caused by the fusion of the inferior poles of both kidneys, which results in a single structure. As you can see in the figure, the kidneys form a single horseshoe shape. As the kidneys ascend from the pelvis during fetal development, they get trapped under the inferior mesenteric artery and remain low in the abdomen. Despite this abnormal development, the kidneys function normally. This developmental pathology is associated with Turner syndrome. The last system we are going to cover is genital embryology, which is a high-yield topic for Step 1. Female genital anatomy is the default developmental pathway. The mesonephric duct degenerates and the paramesonephric duct develops. Male genitals develop due to the SRY gene on the Y chromosome, which produces testis determining factor and promotes testis development. Sertoli cells produce Müllerian inhibitory factor, which suppresses development of the paramesonephric duct. Increased androgens from Leydig cells stimulate the development of the mesonephric ducts. All of the male internal structures derive from the mesonephric or Wolffian ducts, except for the prostate. This includes the seminal vesicles, epididymis, ejaculatory duct, and ductus deferens. The female internal structures develop from the paramesonephric or Müllerian ducts, and this includes the fallopian tubes, uterus, and upper third of the vagina. The lower two-thirds of the vagina originate from the urogenital sinus. If a female presents with fully developed secondary sexual characteristics, an indicator of functional ovaries, but has primary amenorrhea, you should consider anatomical defects as a potential cause. Bicornate uterus is a type of uterine malformation where the uterus becomes horn-shaped at the top left and right corners as a result of incomplete fusion of the paramesonephric ducts. Patients typically have urinary tract abnormalities and infertility. To review, what drug, used formerly to prevent preterm labor, has now been associated with increased incidence of vaginal clear cell carcinoma? That's right, DES. The daughters of women given the drug have increased incidence of vaginal cancer and uterine abnormalities such as T-shaped uterus. This is a review of the important signaling pathways for male development of internal and external genitalia. An important takeaway message from this figure is to understand the pathways in order to predict the phenotype of patients with different abnormalities. For example, if an XY patient could not produce Müllerian inhibitory factor, what structures would be present? Well, let's walk through this together. The patient is XY, indicating that he has the SRY gene on the Y chromosome. This will make the testis determining factor, which will stimulate the formation of testes. The testes, which have Leydig cells, would produce testosterone and cause the Wolffian ducts to form the male internal genitalia. Also, testosterone would be converted to DHT and cause the formation of the male external genitalia and prostate. However, since the patient cannot produce Müllerian inhibitory factor from the Sertoli cells, the paramesonephric duct would develop, forming female internal genitalia. So in summary, the patient would have both male and female internal genitalia and male external genitalia. Males and females have external genital homologs as they originate from the same embryonic origins and differentiate into male or female depending on whether dihydrotestosterone or estrogen signaling is present, respectively. The genital tubercle in males forms the glands penis and corpus cavernosum and spongiosum, whereas in females it forms the glands clitoris and vestibular bulbs. The urogenital sinus differentiates into the bulbourethral glands, prostate, and ventral shaft of the penis in males, and in females it becomes the greater vestibular glands, the urethral and paraurethral glands, and labia minora. The labial scrotal swelling in males becomes the scrotum, and in females it becomes the labia majora. Hypospadias is an abnormal opening of the penile urethra on the inferior side of the penis. It happens when the urethral folds don't close. Epispadias, on the other hand, is an abnormal opening of the penile urethra on the superior side of the penis. It happens because of faulty positioning of the genital tubercle and is associated with exstrophy of the bladder. Hypospadias is more common, and it must be surgically repaired to prevent chronic UTIs. Hormonal control causes the gubernaculums to become the ovarian ligament and the round ligament in the female, and in the male it anchors the testes within the scrotum. The processus vaginalis is obliterated in the female, and in the male forms the tunica vaginalis.